Hello, dear
Hello,
Mustafa. Hello, how are you?
I'm good. I'm good. How are you, my friend?
Thank you, thank you. Ramadan Mubarak.
Ramadan Mubarak. Thank you so much. How's
Ta-
everything? How's Ramadan? All
It's
good?
good. Yeah, it's good. Thank you.
Thank
دعوتك
you.
وعدتك مقبول.
Yeah.
مقبولة.
Yeah, inshallah.
Inshallah.
Inshallah. How's
It's a great
everything?
pleasure to have you.
All good?
Everything is
It's a
good.
great pleasure to have
Yeah,
you.
it's a great pleasure to have you. It's an honor and a long time no see. I miss you.
Miss you
I
more,
really
man, but
like you.
I believe we will be meeting soon for sure.
Yeah, for sure.
For sure.
We will meet each other soon. Yeah.
So,
Okay, how is
how was work during this month?
this month was good. Actually, because we are going for the final holidays and the New Year holiday at Iran, we are changing the season.
Okay.
The clinics are very full, and we have to visit many patients and treat many teeth. Okay, Dr.
Very,
Parisa is here. I'm going to ask her to join us. Hello, Dr. Parisa. How are you?
Hi.
hello, Dr.
Hi.
Parisa.
Hello, Dr. Amar. Nice
How
to
are
meet
you?
you
Nice to
again.
meet you again. But this time it's virtually, it's not in real life.
Yeah, hopefully we have met each other
In
at the real world
Dubai.
in Dubai. Yeah, it was a great meeting with you, and we had very amazing time together. And now we are on a live show on the Endo Leader Show, and it's very good. Very
Long time no see.
Long time no see. Yeah. But I
Yeah.
believe we will be seeing each other soon.
Now we are on internet, on Instagram.
So let's start with hi everybody.
Hi, everybody. Hi. Okay.
yeah, the most famous phrase from Dr. Parisa. Hi, everybody.
It's hi everybody.
You know,
Yeah,
Yes, yes,
we
yes.
want everybody to be high. Because of
yeah.
that, I say hi, everybody. I mean, full energy, like positive energy all around us.
Yeah,
That's really
it's a
nice.
good.
It's really good.
Yeah,
Yeah, it's great. You're sharing very good
yeah.
vibes. By the way.
Okay, thanks. I always love good vibes.
Yeah, that's really nice. It's really nice.
Yeah, thanks. That's very amazing. Okay, now we have gathered together, and I think we can start the session. As you know, this session is about the bioceramic sealers, hurricane of success, or the tsunami of failures. And the main issue is that we want to see if we have success or if we have failures. Is it related to the types of the sealer, especially the bioceramic sealer, which depends on the techniques, it depends on other factors that we haven't followed and we haven't uh, used during our treatment. Okay, Dr. Amber, you are the new one as the live Instagram speaker. So I just wanted to ask you to go for a brief introduction about yourself. I know you are very famous, everyone knows you, but it will be very interesting for us to have a brief introduction about yourself by your own language and by your own.
Okay. I'm Mustafa Anwar. I have been teaching for more than uh, 15 years now. And I graduated 2009. I got my master's degree in 2015 from Ain Shams University in Cairo, Egypt. Also, I got a diploma in healthcare and hospital management from the American University in Cairo in 2013. I have been teaching all around the world at multiple dental institutes. I'm also a visiting lecturer at Ajman University in United Arab Emirates. I have been teaching in Egypt in Nahda University and the British University in Egypt. I have given and conducted courses all around the world in more than 30 countries. And my protocols and my techniques are being already shared all over the world in these 30 countries and many others. Some of my techniques are already being taught in multiple dental institutes in the United States, like Loma Linda University, for example. I have done many courses. I have taught more than 30,000 participants all around the world in my hands-on workshops for the past 13 or 14 years. So this is just a brief introduction about me. My practice is only limited to microendodontics. This is the only thing I can say, and a little bit of restorative dentistry. That's it.
Very good. Your journey and your actually pass through the endodontic is very amazing and impressive, and we have inspired a lot by your works, and we have learned a lot by you specifically on the social media because you have a huge generosity through sharing your knowledge and your experience, and this is a very amazing time that we have the chance of learning from you. Thanks for accepting our invitation, and
It's my
as
pleasure.
long as we yeah, it's our honor and pleasure. And as long as we know Dr. Parisa very well, and she's also very famous, I don't want her to go for her introduction because everyone knows her, and she's a very good member of Endo Leadership. So I just wanted to go and start the session. I want to know about your actual explanation about the bioceramic sealer. What do you explain? And how do you introduce bioceramic sealers to the audiences? For example, is there any category or is there any classification for bioceramic sealer, or is there any specific feature for bioceramic sealers that you want to talk about at the beginning of this session? Okay, Dr.
Is this
Anwar,
for Dr.
it is
Parisa or for me?
both of you, both of you. But
The
Mustafa,
questions are just for you.
I believe ladies first, so ladies first. So I believe Dr. Parisa should start first.
No,
Ladies first.
I even didn't listen to the question.
you are so genius, Mustafa.
Damn
You are so
you.
genius.
Then, Dr. Ali, you should ask me the question again.
Okay, no problem. Please just explain and introduce bioceramic sealers. What do you call a bioceramic
you know,
sealer? Yeah.
you owe me one. Dr. Ali,
One's
you owe me one because of this thing that you done. First of all, I want to say that in my private practice, I'm using bioceramics about 1 year or more. I haven't used that for a lot of years, but I had a lot of successful results. In my daily practice right now, I use bioceramic sealers about 90% of my cases, and I think it's a huge amount, you know. But I didn't shift it that much easily because at the first I was a little bit afraid of the results. But after a while, I thought that, and I had a lot of search on it, like a lot of articles. And I noticed that I'm getting good results in my follow-ups. And after that, I decided to switch from my traditional obturation to bioceramic sealers. And nowadays, in my daily routine, I think about 90% of the cases I'm using bioceramic sealers, and I'm satisfied. Now, dear Dr. Amber, start the presentation.
Yeah, Mustafa, it's your turn.
Okay.
Yes.
Well, for me, when I go for any hands-on course or for a lecture about bioceramics, the first thing is that I start with it's that the bioceramic sealers has changed already the game of obturation in endodontics, because we all know that the bioceramic sealers, they are not only sealers, they are root canal filling materials. And actually, having the bioceramic sealers in these days, in these years, it made us do simple and efficient 3D obturation, especially when we are talking about reputable or famous brands about bioceramic sealers, which can help us to do more efficient 3D obturation due to many advantages. And I believe this is not the topic for now, or this is not the issue to talk about now. But the bioceramic sealers, they are root canal filling materials. So they are totally different from the resin sealers or the zinc oxide ethanol-based sealers or the calcium hydroxide sealers, whatever the type of sealers we are talking about. So it's a root canal filling material. We can use it without any gutta-perca. However, we are using the gutta-perca for only two reasons. First of all, or the first reason is to act as a piston effect in order to push the sealer into the root canal, into all the root canal spaces. And the second thing is the bioceramic sealers, even though they are root canal filling materials, however, when they are all set, they get hardened. So it's very difficult to do retreatment. So the gutta will act as a pathway for retreatment. So that's why it's totally different technique. We are already aiming, I believe during lateral condensation technique, when we were teaching the students, we used to tell them, go for maximum amount of gutta and less amount of sealer. However, in bioceramic sealers, it's totally the opposite. You can go for the maximum amount of sealer, no problem at all.
Exactly.
Especially if you are using a good brand or a reputable brand, according to some articles. So this is simply how I start my presentation about, or the introduction about the bioceramic sealers.
Very good. Thank you. That's a good point that you have talked about and mentioned. I think the bioceramic sealers have more than 30 years history in endodontics, and it is not a new material in endodontics, but it has been accepted recently because of the articles and researchers that we have in the literature. First, it was introduced based on the concept of MTA, because many endodontists and manufacturers have seen that when we use MTA as intracanal filling material, we have good result because we can seal the area very impressively, and they have thought that we can use MTA in the form of sealer in order to fill the root canal. And as Mustafa said, the bioceramic sealer concept is based on an obturating material. So it's not just a sealer, it is an obturating material. So we can use it as the main material of the obturation material. But the question arises from that if we want to use bioceramic sealers, what are the techniques for using the bioceramic sealer? Many claims that the single cone technique is the most available and is the most efficient way to use bioceramic sealers. But also we have other techniques. For example, we can use it with lateral compaction technique. We can use it with warm vertical obturation technique. And I want to know your concept about using bioceramic sealers with these obturation techniques, and which one do you prefer, and why do you go for each of these techniques that I've thought about?
Okay. First,
Okay,
you begin or me?
Yeah,
Me or Parisa?
Mustafa, it's your turn.
It's my turn.
It's your turn too.
Okay. So you are now standing with Parisa. Okay. Okay. So for the bioceramic sealers, actually, we have two main techniques. This is in my opinion. We have many techniques we can use bioceramic sealers with, but the main two techniques, it's the cold hydraulic condensation technique, or it was even called synchronized hydraulic condensation, but nowadays we just call it the hydraulic condensation technique based on the calcium silicate cements, the bioceramic sealers. So this is the first technique, and actually, let's say that the nickname of this technique is the single cone technique, or single matched cone technique. So this is the first one. The second one will be the hot modified technique, and actually this is the only two techniques I'm using the bioceramic sealers with. But for the last 2 or 3 years, I'm only using single cone technique, and I'm not using even the hot modified technique anymore. Because I believe with single matched cone, we can do everything. Yes, there might be some modifications of this technique depending on the complex anatomy we are facing. However, I can use single cone technique in 99.9% of all the cases. I don't want to say 100%, but actually you can do it in 100% of the cases. I'm just leaving this 0.1% in case you want to say that there is some exception or something. But however, for me, no. I'm using mainly the single cone or single matched cone technique. I just inject the bioceramic sealer into the coronal half of the canal. I start using single matched cone, having the same tip size, the same taper as the master apical file. I just put it inside the canal, and that's it. I cut off the gutta on the orifice level. And in my practice, I not only cut it on the orifice level, I even go below the orifice level with 2 millimeter. So I can inject after that flowable composite or whatever the material I have into the coronal 2 millimeter of the canal, so I can be sure of the coronal seal. The other technique will be the hot modified technique. And actually, the hot modified technique, it's nearly the same as warm vertical compaction, but the only difference is in the warm vertical compaction or in the continuous wave of compaction technique with resin sealers, we used to cut the gutta working length minus 4 millimeter. But in the hot modified technique, in case of bioceramic sealers, we cut the getaperca only from the coronal third of the canal. So we go only 4 millimeter into the canal. And then after that, we start compacting the getaperca, and then we inject thermoplasticized getaperca in the coronal 4 millimeter of the canal. And now we have done the hot modified technique. But actually, why to do that if I can achieve everything with single cone already? If I can just apply one single cone, and that's it. Why to shift to hot modified technique? This is why I'm using single cone technique in all my practice. Yes, if there is a wide canal, I might add one cone. It's not a lateral condensation, just adding one extra single cone, having large tip size and large taper, and that's it, in order to have a coronal seal by getaperca. But no need to go for hot techniques as long as we have bioceramic sealers.
Very good. Thank you.
Thank you.
I will go for my comments, but I will ask Dr. Parisa to share your technique.
I use a single cone technique for a lot of canals, but I think like in mandible molars, distal canal, or maybe in maxillary molar, the palatal canal, that's about oval, and it's not just round. Maybe I use like not just one cone. Maybe I will put one or two beside the master apical cone, but in other canals, like in the mesial ones of the mandibular molar or in MB1, MB2, I agree with Mustafa, and I really just use one gutta percha. I exactly do the same strategy as yours. I just inject the sealer into the canal, and then I will put just one gutta percha in it. Dear Mustafa, when you were explaining your technique, a question came to my mind. I want to know, because you told me that single cone technique is like you use it, and when we have such kind of technique, why we should do like modified technique, or maybe other techniques that we have hot modified. I want to know that do you believe in this phrase that it's easier to use bioceramic sealer compared to resin-based sealers as a technique?
Yes, it's much easier to use bioceramic sealer. And actually, when you are using the resin sealer, you are only stuck with three techniques. It's either the lateral condensation as a cold technique, or two other hot techniques, which is the warm vertical compaction or continuous wave of compaction technique. So with resin sealers, you are going to choose one of these three. And actually, when you are going to compare the easiness of the procedure for single cone technique with bioceramic sealer, or using resin sealer in any of the other three techniques, it's much easier to just inject bioceramic sealer in the coronal half of the canal and just apply one single matched cone, and that's it. However, in the other techniques, you are going to put lots of auxiliaries in the lateral condensation, or you are going to have another tools. And this is another point. If you are going for continuous wave of compaction technique, you don't only need the getaperca and the sealer. You need to have the tools required for that. Like for the gun, for example, in order to inject the thermoplasticized getaperca. So it's more about adding more tools to your armamentarium instead of having just one simple syringe of bioceramic sealer. So this is another subject to talk about. You are adding lots of tools, lots of devices. You are adding lots of time. And I believe nowadays it's the era of simplicity. We have to simplify most of the steps of the root canal treatment, because already root canal treatment, it's a complicated procedure. And it's a very, very precise procedure when it comes to using instruments, to doing disinfection. It's very meticulous procedure. So when we have the chance to simplify things, why don't we go to the simplified procedure? As long as it's supported by evidence-based, it's supported clinically, and we are having good results with it. So these are the three things that we should follow. So why not to go for an easy procedure instead of making things difficult for our life or our daily routine?
Very good, very good. That's it. I use the technique that both of you have talked about, which is passive lateral compaction. It means that you will use a lateral cone, but in a passive manner. You don't need to use any spreader, because some places that when you put a spreader inside or beside to a master cone, you will remove many amounts of the sealer, and you cannot be sure that you have filled that area with the gutta percha. So you may have more void with lateral condensation technique. But passive lateral condensation technique refers to a technique that you just put another cone beside to your master cone, and you will have more amount of gutta percha inside the canal. But I want to go for the main topic that we are going to discuss about. What are the reasons of failures when we use bioceramic sealers? For example, you may have faced many cases that you have removed the gutta percha from the root canal system, and you have seen that the sealer is not set. The claim is that, is it related to the sealer itself, or it depends on the techniques? What are the reasons of failures, and what are the reasons of actually we may face the sealers that have not been set? I want to go for these details. What are the criteria? For example, what should we follow in order to have a complete setting of the sealer? Many claims that the sealer may burst out from the lateral canals, from inside the canals because of the body fluids. But as long as we know, we have many cases that are success. And the article says that, okay, we have the same success in comparison to resin-based sealers and other obturation techniques. I want to know about if you have any idea or if you have any concept about the reasons of failures based on bioceramic sealers. Is it technique sensitive or not, and what are the criteria? It's a hard question. I want to start with Mustafa.
Okay. I mean, now you are on the same side with Parisa. Okay, okay. I got it already. I got it.
I can start, but I will just have a small speech, and then you speak aloud for us and explain all of the details.
Okay.
It doesn't matter.
It seems that Dr. Parisa is the volunteer of this question.
Yeah,
Dr. Parisa,
I'm okay with it. You know, one of the things that I'm confused on is, I think, the moisture in the canal. Okay, I think it's a main factor, or maybe it will have effect on the setting time of the sealer. Then, first of all, maybe I will say that moisture and if our canal is like dry or semi-dry or wet, it's a kind of important factor. This is one. And I want to know that what's the term of failure? What do we say it's failing? You know, is failure, when you say failure, do you mean that like we have a kind of infection or inflammation around the root, and after like about a time we see that a bone is regenerating or not? Or failure is like maybe the anatomic structures around the root, we are affecting them, like in a mandibular molar, maybe because of the distance between the molar and the inferior alveolar artery or a nerve. These are kind of structures that are around the root, and maybe these are kind of factors that are important. Is this a failure? We should know that what do we mean of the term of failing. But if I want to say specific factors, I'm thinking about the moisture, about the setting time. If is heat kind of disturbing my setting time, or the specific things about the sealer, and how should I inject it in the canal? In which cases, with which preapical status is can I use it? Like in a necrotic tooth or a tooth with infection, is it right to use bioceramic sealers, or should we have 2 or 3 sessions, use like intracanal, like calcium hydroxide or other kind of intracanal medicaments in the canal? I always think about these kinds of questions, and I think all of them we should like consider them and see which factor is more important and what's the effect on our treatment, on our success or failing. Ava, you tell us.
Okay. So actually, I believe Dr. Parisa has covered many points already regarding this question, and I believe the answer for Dr. Parisa is very nice, and it's a broad answer. But before proceeding to this question, I would like to thank you, Dr. Ali, for mentioning that the word passive in passive lateral condensations, because we don't want to push the sealer out of the canal coronally. If we use any spreader, the sealer will just be wasted coronally. So the word passive is very important. And actually, I would like to thank you and highlight it for the audience that the word passive is very, very, very important, because you need the sealer to stay in the canal. You need the sealer. We are just adding the cone for having a gutta perca seal coronally, but we don't want the sealer to be pushed out of the canal coronally. So adding a passive cone, this is the exact term. So thank you so much for that.
My pleasure.
Thank you. For that question, for that tough question, actually, you let me get a paper and pen and start writing, because I need to, I need to organize the points that I need to.
It needs 1 hour talk.
Yeah. Yes, exactly. So I'm going to simplify it, and I believe my answer will be coinciding with the answer of Dr. Parisa already. But maybe I will just mention it in a little bit organized way, because already I had the time to think and I had time to write. On the contrary, Dr. Parisa didn't have the time. But let's start by wetness of the canal, or the word wetness, not moisture. I'm talking about wetness. So when I say wetness, we are talking about two things: the irrigation and the infection. So if we have a wet canal because we didn't remove completely the irrigant, so this is one of the reasons for the failure of the bioceramic sealers to set, or maybe for the wash out of the material. And if at the same time, if we have an infection periapically, and this infection has already some serious oxidate, or even has some little pus coming from the canal, and we decided to obturate, so we don't have a dry field inside the canal. So this is another reason for the material not to set, and actually being an acidic medium due to the infection, and the material is alkaline, so some sort of neutralization will happen, and there is no set of the material. So the first source of failure will be wetness, either for the infection or irrigation. The second thing will be related to the material itself. And when we say the material itself, we are talking about the filler content of the material, because many materials are now present in the market. So if we have lots of materials and we cannot decide what's the filler percentage in each material, so here comes the problem. And I believe my friend Filippo Cardinali and our professor Josette Camilleri, they covered an article already in 2023, and it was talking about the filler content of some of the bioceramic sealers present in the market. And actually, they discovered that some of the sealers has around 15 or 20% of filler content only. So we are talking about a liquid. We are not talking about a bioceramic sealer. You're just talking about a solution. So what if the filler content is very low to the extent that you cannot help the material to set? So what will happen to the material? The material will just be washed out. We're having lots of moisture due to the material itself and less filler content. And actually the filler content, it's a part of the material which helps for the setting of the material. So that's why the setting time is also another factor, because if the setting time is going to take a very long time in order to set, so there will be lots of chances and lots of time for the wash out of the material by the body fluids, either the dentine moisture or the fluid coming from the preapical area, or whatever, from the surrounding tissue related fluids, whatever. So that's why the sitting time also, it's a factor related to the material itself. It should be less. And when we say less, we are talking about 3 hours, 4 hours, 5 hours, depending on the material. But actually, there are some materials in the market, it might take up to 72 hours for the bioceramic sealer in order to set. And this is very, 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 very long time, because 72 hours means that for sure the surrounding tissue fluids will affect negatively the setting of the material, and will affect negatively the material itself, and there will be washout phenomena, which means that the material will be diluted and there is no material at all, which we already injected already. The third reason will be the technique itself. And when we say the technique, mainly I'm going to talk about the heat. And I believe Dr. Parisa already has mentioned it, that the heat already might affect negatively the physical properties of the material and at the same time the setting time of the material. Bioceramic sealers are hydrophilic. They love moisture. So sometimes when we use excessive heat during the obturation technique, this heat will just take the moisture out of the bioceramic sealer. So now you have already compromised the content of the bioceramic sealer or the flowability of the bioceramic sealer, and it might affect also the hydration phenomena or the hydration equation for the bioceramic sealers in order to set. So this is another reason for failure of the bioceramic sealer. Last but not least, it will be the operator based. And if the operator is not using the bioceramic sealer in a correct manner, I want to say it simply, if he doesn't know the know-how, if he doesn't have the idea of the know-how to use a bioceramic sealer, yes, it might be an easy technique. However, you should learn the know-how of the technique. You should learn the idea behind the using of bioceramic sealers. So it will be operator based. If you didn't use it correctly, you will end up with failure.
Exactly.
Exactly. That's
I'm so sorry for taking so long. Sorry for taking so long.
The points that you have talked and mentioned are very, very important, and all of us, we should consider. Specifically, I just want to go through this discussion because I want to say, I don't know if you agree with me or not. I think, in my opinion, a single cone technique with bioceramic sealer is still technique sensitive because you have to follow many rules and many steps. For example, you have to use rubber dam for your isolation. If you don't use rubber dam for the isolation, you still don't have a good disinfection and good irrigation of the root canal system. You have to completely dry the root canal, as Mustafa have talked about. If you have any persistent drainage through the root canal, many think that it is equal to MTA. MTA is it's a material completely different. If you have any persistent drainage into the root canal system, you shouldn't obturate the root canal system because you have acidic pH in the root canal and the sealer will not be set. And the second point is that about the irrigation protocol. I have read many articles that they say that if you leave any EDTA at the end of the treatment inside the root canal, the EDTA may hinder the setting of the bioceramic sealer. So the final irrigation is very important. You shouldn't have leave any hypochlorite or any EDTA inside the root canal system because the remaining amount of those irrigation solution will not let your sealer to be set. And my question, the last question, and one of my other question is that about preparing the post space. For example, many claims that as you talked, for example, we have to wait 72 hours for the sealer to be set completely. Can we prepare the post space at the session that we have obturated the root canal, or we have to wait for the final setting of the bioceramic sealers? I have talked about this topic with one of the endodontists, and it says that he has prepared many cases at the obturating session, and all of his cases was successful. And he has used heat carrier in order to prepare the post space. But as you talked, the heat may have a negative effect on the final setting of the bioceramic sealer. The question is that can we prepare the post space at the obturation session, or we have to wait for another session? Because I think this is an important factor for having a good and successful treatment, because the final setting of the sealer is very important for the success rate of the treatment.
I would start. I will go ahead. Okay. No, usually I do the post in the same visit of obturation. It's so simple. Like when you inject the bioceramic sealer, if you are going to go for single cone technique with bioceramic sealer, and you are not going to do any post, you start injecting the bioceramic sealer in the coronal half of the canal, and then you apply the master cone. So this is for the single cone technique in case of no post encore. But in case you are going to go for post and core, you shouldn't inject the bioceramic sealer in the coronal half. You should inject the bioceramic sealer in the apical half. However, you inject it in the apical half without any pressure. Just be sure that the tip of the bioceramic sealer is free inside the canal. It's not engaged. It's not locked into the canal. There is no injection under pressure. Just inject the bioceramic sealer in the apical half, and then you apply the single master cone. And then you get the System B or the down pack pen. You put it just in the first 5 millimeter in the canal. So for example, if I'm having a working length of 22 millimeter, I will adjust my System B on 16 millimeter, because this means I'm getting only 5 millimeters into the canal. And then I will just go in 3 seconds. And the temperature of the System B at that time, it will be 150 degrees. And I will just take the System B into the canal. I will stop at that time, at that level, and then I will cut it and seal off the getaperca at that level, and then I will just take my System B off. And this is simply, I have created a post space in the same visit with obturation of single cone with bioceramic sealer. So it's very easy to do single cone with bioceramic sealer, and it's very easy to do the post space as long as you are using the correct technique. The point is, if I increase the heat, the temperature of the System B, or if I already increase the time, and like more than 6 to 7 to 8 seconds inside the root canal, now I'm transferring more heat to the apical part of the canal and to the apical part which has already the bioceramic sealer, and now I'm affecting negatively the bioceramic sealer material. So it's all about the technique related and operator related. So if you are using the proper technique, and if you are having the know-how which I mentioned earlier, no, you can do the post and core. And actually, for the past 7 years, starting from 2018 and at the end of 2017 even, I'm using bioceramic sealer with and I'm doing single visit with bioceramic sealers, and I'm using post and core at the same visit of obturation, and I have lots and lots and lots of follow-ups where you can see that there is beautiful tissue repair, beautiful healing, and there is lots of bone formation, and everything is just going fine. So it depends on the technique. It depends on the technique. And of course, let's not forget one important thing, the material itself. And this is just one thing, because every day we are having a new bioceramic sealer present in the market. I don't want to mention any brand names, but of course, you know that we had 2 years ago, there was a brand present in the market, and it was a famous brand. And just after like 7 or 8 months, it was just withdrawn from the market because it wasn't that good. So we shouldn't just follow any brand. We have to test this brand. We have to test this bioceramic sealer. It should be clinically proven to be okay. It should be already well researched, and then we can start using this bioceramic sealer.
Yeah, that's a good point. Actually, we have some sealers in the market that claims that they can tolerate the heat. And also we have some articles about some brands that they can bear the heat and the one vertical actually technique, but it depends, as you said, it depends on the sealer and type of the brand. Some brands they cannot be used with heat, but some they can. And depends on the sealer. Can we use rotary and mechanical actually instrument in order to prepare post space for bioceramic sealer? Because as you know, when we want to use those rotary system, for example, Gates Glidden, you may actually remove the gutta percha from the root canal system. I want to know if it is possible to use this rotary instrument or not for having
I don't use
space.
No. I never use any drill. I never ever use any drill for the post space. Only the System B, and cut it at the level of the post, and then I compact with the plugger, the getaperca. I am sure that there is a getaperca seal. I'm having a post space of 4 to 5 millimeter, mainly 5 millimeter. Then I will just get the post, which has a perfect fit up to the working length, and this will be my post, and that's it. But I'm not doing drilling anymore. For the past 7 years, there is no drilling anymore, because it might affect the root already. I might having micro cracks. These vibrations are not good for the dentine itself. It might go for cracks, or might even end with fracture or even perforations in non-experienced hands if you're going to go for drilling. And I have lots of cases being referred to me, lots of prosthodontists trying to do a post space using drills, and they end up with perforation. So they refer back the case to me. So that's why
Yeah.
I believe that the endodontist is the best operator or the best clinician in order to place the post. I'm having already the canal already in front of me under isolation. I can already do whatever I want with the canal. I can prepare the post space without anything. I can already control the amount of gutta perca that I'm going to leave, and that's it. And that's it. So simply.
Yeah, exactly. When I want to refer the treatment to other specialists, I always write down the letter to them, and I will write about my obturation technique, because when I write I have obturated this case with single cone technique, they know that they cannot use rotary system, for example, gate Glidden, in order to prepare post space, because if they want to use gate Glidden, they may remove all the gutta percha from the root canal system. And this is one of the factors that I wanted to talk about, and you have mentioned completely about the details. Okay, and I want to
But
talk
however,
about
Dr. Ali, by the way, I don't wait for 72 hours for the post or anything. I never
that's
wait.
yeah,
I never
yeah,
wait.
that's
And
very
actually,
important.
the sealer I'm using already, it has a setting time of 3.5 hours, so it's a good sealer already. So it can give you the time for manipulation and doing obturation and putting the post and everything. And when the patient just goes home, and after the anesthesia numbness just fades away, the material is set already. So there is no time for the washout phenomena.
Yeah, and based on articles, yeah, it is very safe to prepare the post space at the obturation session,
Yes.
because
Yes.
the times may lower the success rate of your treatment.
Exactly.
Exactly.
Sorry, and Dr. Mustafa, I want to say something, because the literature always I have read suggests that we can use fiber post contextually to the endodontic procedure, instead of using like a delayed post after 2 or 3 days. I mean, maybe if our dentist that we're working wants to complete our treatment, maybe or the patient has a lack of time, maybe we can use a kind of fiber post in that time. Do you agree with me, like using a fiber post extremely, I mean, in that session that we're obturating, not like
Yes,
2
yes.
or 3
This is
days?
this is what I've been doing for the last 7 years.
Okay,
Yeah.
then you agree,
Yes, yes.
because
Yes, for
okay.
sure, for sure, for sure. Doing the post encore in the same visit, and as I mentioned already, that I believe the endodontist, he is the most capable clinician in order to place the fiber post without doing any drilling. I know the size of the canal. I know the shape of the canal. I'm having magnification. I can see everything about the canal. I know perfectly the size of the post, which can have a perfect fit up to the working length, having friction with the sides. So I'm the best clinician in order to place. I'm not saying the prosthodontist cannot do it. He can do it. But actually, if already I'm in the middle of the procedure and everything is just fine in front of me, why not to place the fiber post? And even placing the fiber post will ensure that I'm having a perfect coronal seal.
Okay.
So I'm already doing one of the objectives of the obturation, having coronal seal, having apical seal, entombing of residual bacteria. So the coronal seal is one of my main objectives also. So this is one of the other reasons.
And you told us that you inject the sealer about like in the apical segment. How can you fix it exactly in that position, not in the coronal? Because in our traditional way, we just inject a
In the
sealer in the
coronal turret.
coronal. Yes, I
Coronal,
want to
yes.
know if you want to, like, you're not postless and you want to use like fiber posts or other things in the coronal part. How do you know the exact place of the injectable syringe to just locate it in like a place that the coronal segment of the canal will not be injected by sealer?
No, no, no. We have to differentiate between two things.
Okay.
Injecting the sealer in the apical half, injecting the sealer in the apical half means already that I'm just putting the sealer in that part. And when I just put the cone, and when I cut the cone, at that level, for example, I'm leaving only 5 millimeter for the post space. At that time, of course, I'm going to have remnants of the sealer on the corona part. After that, I will just wash the excess of this bioceramic sealer just by cavitron or ultrasonic scaling and using water only in order to remove the excess of the amount. However, the sealer which is already injected in the apical half, I'm being sure it is still in place because already I have put a single cone, I cut it at that level, I have done compaction, I'm having good coronal seal with gutta perca at that level of the canal in the middle third, for example, and the rest of the sealer in the coronal third is going to be removed with ultrasonic scaling, and that's it. And then I'm going for dryness and then for the post-encore. If your question means how to place already the sealer in the apical half only, I guess
Yes.
you have to pay me for now because this is a private course. Okay, so if you are thinking about how to place the sealer in the
You
apical half only,
noticed that what my exact question was, but you told us something else.
okay, so in order to do that, you have two techniques. Okay, if you are already very experienced with the bioceramic sealers, then it will just come by the experience and you can just place the cone. And if you are using microscopes, so under high magnification, you can see easily that the tip is already at the start of the apical half of the canal or even in the middle third. And when you are injecting and taking it out, you are sure that the apical half of the canal is being or having the bioceramic sealer. If you cannot do that and you don't have the experience or you don't have the microscope, you can just add a stopper onto the bioceramic tip. And also you can do that even in short canals. Adding this stopper, and then you are going to go for working length minus 6, working length minus 6 or working length minus 5. So when you just put the bioceramic tip and you adjust the stopper on the working length minus 6 millimeter, now you are being sure that when you inject the bioceramic sealer, it's being injected into the apical half of the canal, having a little bit part of the middle third and then into the apical part. So now we are being sure of the material. And because of the flowability of the material, when you insert the cone already, it's going to push the sealer more apically. So this is just the two techniques, depending on the experience and depending on the operator.
I think
Very good.
I
Thank
saved a
you.
lot of
money.
with the explanation.
Yeah. Okay.
Thanks.
Regarding the question that Dr. Parisa has asked, I want to share a video that I really like this technique. This technique will help you to insert the bioceramic sealer exactly at the point you want inside the canal. This technique was firstly presented and introduced by Dr. Riccardo Tonini, and I really like this technique. He has used e-reflex tips because it is flexible and you can put a rubber stop on it, and then you can inject the sealer inside the canal very safely because it is side vented. There is no actual risk of extruding the sealer beyond the apex. And this technique I think is very safe, and this is one of the techniques that I really use in order to inject the sealer at the apical third of the root. You can easily use this technique like this. You can see, as Mustafa said, if you have a dental operating microscope, you can use this technique. See, the e-reflex goes exactly to the point of the apical third, and you can inject the sealer inside the canal very easily and safely by this technique. I really like this technique, and because you have talked about this, I just wanted to share this video by Dr. Riccardo Tonini.
I'm going to highlight two things here. The first thing is he is not using the reflex tip as it's side vented. No, he's using the reflex tip, but after cutting about 2 to 3 millimeter from the tip size already. Because already, if he is using the reflex tip, it's not, the bioceramic material is not going to come from the side vent of the tip. He has to cut about 2 to 3 millimeter. And I believe we were doing this technique, and this is the second issue. We were doing this technique when already the tips of the bioceramic sealers present in the market were already not having the same flexibility of the reflex tip, or maybe they have some sort of waste. But nowadays, I believe all the bioceramic sealers, and I'm repeating it again, all the bioceramic sealers, their plastic tips or even whatever the type of the tips, it has very good flexibility and it has a very small size, and they are not having any waste, uh, not any waste, but they are having minimal or
Minimum.
very minimal residual waste into the plastic tips. So there is no need to transfer the air flex to an injection tip. It's not that effective when it comes to the because you are going to cut already from the tip. So so you are just transferring it again into an end vented, not side vented.
Yeah, exactly. Yeah, that's a good
I'm
point.
not sure if my
I
laptop
noticed that. Yeah.
is yeah, you can see here. I'm not sure it's clear or not, but I'm going to try to show something on my laptop. Here is just a
Can
case.
can you use your front camera in order to show your laptop? Is it possible for you or not? Because the front camera
Uh,
has the more high
let me
quality.
try.
Yeah.
Let me. Okay,
Yeah.
just
But
wait.
you have to rotate your camera. Don't rush.
Okay, just wait. Is it
Very
clear
good.
now?
Yeah.
Yes.
Very good.
Okay. So here I'm just going for the bioceramic sealer injection because I'm going for in the apical half because I will go for the post and core. I will just repeat it because it was not stable. Here. Injection of the bioceramic sealer in the apical half. Here is the cone. And here is the system V, and I'm going to cut the getaperca just 5 millimeters below the orifice in the middle third. And now I have the post space. So the mesials was done with single cone technique using bioceramic sealer, and the distal same single cone, but I have already created the post space for the post and core.
Very good. Thank you. Thanks for your amazing clips. It,
My pleasure. My pleasure.
the quality was high, and we have enjoyed a lot. Thank you, Mustafa.
Thank you so much.
For the
My pleasure.
distal canal, which good haircut did you use? That was,
Yeah, 50
stick
tipper
out.
6. It was Protipper Next. X5 by Protipper Next. It
Okay.
was 50 tipper 6.
Okay.
Okay. And I have another question, and it can be my last question because we are running out of time, about sealing the perforation. For example, if we have lateral perforation, specifically the strip perforation, some make claims that you can use bioceramic sealers in order to seal those areas. And my question is that, is it possible to repair specifically the strip perforation with bioceramic sealer or not? As long as I know, and I do in my daily practice, I use MTA and MTA-like materials in order to seal the perforation site. I know it's very hard, it is very technique sensitive, but I don't rely on bioceramic sealers to completely seal those perforations. I want to know your concept about using bioceramic sealer for repairing the strip perforations.
Okay, it depends on the size. Like what's the size of the strip perforation? If it's a very minute size, and if the so number one will be the size, and number two will be the location, and number three will be what I'm going to do for the corona restoration. So if the size is very minute and very small, no, I can go with the bioceramic sealer. No need for bioceramic putty. And even because I'm not using MTA anymore, I'm using bioceramic putty. So there is no need for MTA or bioceramic putty. However, if the size is large, no, now I'm going to shift to the putty material or the MTA. Second thing would be the location. For the strip perforation, mainly it comes in the coronal third. But sometimes it might be more in, like,
Difficult.
for example, at the start, at the junction between the middle third and the coronal third. It's not that near to the orifice. So it might be covered already coronally by the getaperca. And the size is small. So yes, at that time, I'm going to use also the bioceramic sealer. No need for the putty or the MTA. The third thing would be, what's the type of my corona restoration? For example, if I'm going for post and cure, no, now at that time I have to seal the strip perforation using bioceramic putty or MTA. And after that, when the material is set already, that's why I would prefer at that time to use a fast set material in 2 minutes or in 20 minutes or up to 20 minutes, depending on the material you're using. And then after that, I will go for the post and cure. But if I'm not going for post and cure, no, I can use bioceramic sealers at that time.
Okay, what is your idea, Dr. Faisal, about
I completely agree with Mustafa.
Thank you.
Because
Thank you.
when it's small, we can use like bioceramic sealers. But yes, when the amount of perforation is a little bit more bigger, maybe it's not safe, or we can seal it with other materials like putty or MTA or other material that are biocompatible, and they can have a fast set, so we don't have kind of extrusion in that place. I agree with him.
Thank you.
Very well,
And I
but
think he explained completely.
Thank you.
thank you, Mustafa. But
Thank you.
my concern is about the sealing ability of the bioceramic sealers in comparison to MTA, because at least nowadays, because I haven't read any articles. If you have any articles or papers in the literature regarding the repairing the strip perforation with bioceramic sealer, we can talk actually more specifically and more evidence-based. But my main concern using bioceramic sealer for repairing the strip perforation is the sealing ability of the bioceramic sealer for repairing the perforation. But I think we may have still some source of micro leakage around the bioceramic sealer at the perforation side. As long as Mustafa said, if the perforation size is very small, we may rely on the bioceramic sealer, but sealing ability. But for the large areas of the perforation, I don't think
you cannot.
You cannot rely on. The bioceramic sealer cannot act as putty or MTA-like material. They may wash out easily, or the sealing ability of the bioceramic sealer is not as good as MTA for large perforations areas. And thank you for the good points and for categorizing these types of perforations in those notes and those points that you have talked. Very insightful. Okay, is there any question? I have read a comment and a question which was about the retreatment ability of the bioceramic sealers. The question is that is it possible to
Mustafa's technique of retreatment.
Everyone is
just
here.
Mustafa technique, nobody else.
Yeah, they are here because they don't want to pay for your courses and they want to know everything, every details, every key points.
Parisa will pay for them. Parisa will pay for them.
Oh my God, no!
So actually, bioceramic sealers, I have a very common quote which I say about bioceramic sealers. Bioceramic sealers are very difficult to be penetrated, but they can be easily brushed out. So the bioceramic sealers, and this is the role of gataperca. This is the role of single cone gataperca, which you have already inside the canal. When you already go with the rotary files, you can remove the core of the obturation, the gataperca core already inside. In case you are having an obturation with a single cone with bioceramic sealer, you can remove it so easily because it's just gataperca. And we already have lots of techniques. It's not our topic for today, but we have lots of techniques like manual files, rotary files, system B, gataperca solvents, whatever you're going to use in order to remove the gataperca. The question is, when we remove the gataperca and it's going to be removed totally from the core, what about the bioceramic sealer, which is already present on the wall of the canal? So this is the question. If already we use bioceramic sealer only without any gataperca, you cannot do retreatment, because it will be very difficult to dig into it and you will have to use ultrasonics for the whole canal, for the whole length of the canal. And of course, if you are having a curved canal, this is very, very risky situation. That's why we are not using the bioceramic sealers alone. Whenever we have the gataperca, and this is just a blessing at that time, so we remove the coronal part of, we remove the gataperca from all the canal, And then here comes the remnants of gutta perca on the canal walls and the remnants of the sealer. Now you can use your rotary files and you start brushing out. And when you do brushing motion all around the canal walls, most of the sealer will just come out as powder. It will be coming out in a powdery form because already you are, like for example, this wall behind me. If I'm having a scrapping paper and I started to do scrapping here, it will fall off as powder. So this is the same concept which goes for the bioceramic sealer. So it's difficult to penetrate the bioceramic sealer, but it will be easy to be done. Why? Because we have gutta perca, because the penetration will be done through gutta perca. The hardest part, which is the bioceramic sealer, now already you are inside the canal, you have the bioceramic sealer around you, start brushing the bioceramic sealer all around the walls. And I believe one of the files, which is maybe I will not mention the name, but it's already cross section and its design feature is very, very, very nice. It can help you to do scrapping motion in order to move on all over the canal walls. And when you do this brushing motion, or even the Europeans love to call it sometimes painting motion, because you're just doing like a painter. And when you go all around the canal walls, it will be very easily coming out of the canal. And if you still have some remnants, of the bioceramic, you shouldn't go for increasing the canal preparation, because now you are jeopardizing the fracture strength of the root and fracture strength of the tooth. So we affect at the end the pericervical dentine and affect the fracture strength and the survival rate at the end. So we shouldn't be doing this. So if we still have some minimal remnants on the canal walls, it's okay. Just go for your disinfection protocol and just leave it.
Yeah, but the problem is, I think, is about the underfield obturation. The underfield obturation, because the underfield obturation, the canals, you have some bioceramic sealer beyond the gutta percha inside the canal, and those cases are, I think, are very difficult in order to gain patency. And we have some articles in the literature about gaining patency for bioceramic sealers. Some brands have the better ability in order to be removed, and we may have a better chance of gaining patency. But for many brands, it is not possible to gain patency for the underfield obturation techniques. And what is your technique for those cases?
No, like I don't want to say something. I want to say something, but at the same time, I want to be silent at that time. Because already when you no, because when you are saying that I'm a sealer and I have how to say it, I have the ability to be retreated. This is not good thing, because when you say that I'm a bioceramic sealer and when you are going for retreatment, I can be easily removed. It means that you are already not set, because you are already having high filler content. If you're a good sealer, you're having a high filler content. You're having zirconia, alumina, silicate, glass ceramics, bioactive materials, bioinert materials. All these materials, when they are all set, they are very hard. So if it's very and truly hard, you cannot penetrate it with rotary files. And in order to dig, you're going to deal with it as a calcified canal, having lots of rotary files, having manual files, having carbon steel files, using some definders, using lots and lots and lots of, so using ultrasonics. So if it's easy to penetrate the bioceramic sealer, it means that already the sealer has not set, or the setting time or the filler content is very low in this sealer. So when it's set, it's not that hard. So it's a shaky thing, and I believe it's a shaky thing. So I'm not going to go with it, because if the material is already completely set and it's a very reputable material and a famous material, no, it will be very difficult to be removed because it's already set and everything. So yes, there might be some articles, I have read them, but not everything I read I just totally agree. Sometimes I have my own opinion until some more researchers can support this evidence, or sometimes they can come, they dis-support this evidence. So we can still wait about that.
Yeah, you're right. Actually, I've heard some solutions that is going to be in the market, and the solution is that the solvent of the bioceramic sealer. I don't know if you have heard about that solvent. I don't want to go for names, but some companies have started to invent to invent a material, to invent a solution that can dissolve the bioceramic material. I think the main disadvantage of the bioceramic sealer is that there is no solvent for them. For example, we have alcohol for resin-based sealers, but we don't have any solvent for the bioceramic sealer. We have chloroform for gutta percha, and I think in the near future and the future perspective and the future of the bioceramic sealer is the dissolution solvent of those bioceramic sealers. I don't know if they are going to work or not, but the future path is, I think, would be something like that for the bioceramic sealers.
I remember many years ago, like 5 years ago, something like this, or maybe 4 years ago. I was already in a conference, and there was a very big exhibition, and there was a Korean company, and this Korean company, by the way, it's totally unknown. It's just a Korean company. He's not focusing on the endo products. He's just dealing with some chemicals and stuff like this. And he knows about the MTA, and he knows about the bioceramic putty material, and he knows about the bioceramic sealers and everything. And this Korean guy, he was talking to me, and then he told me, by the way, I have a solution which can remove the MTA and the bioceramic putty material.
Oh my
And
God.
I remember at that time, that was 5 or 6 years ago, by the way. At that time, he gave me a very small amount. It was just like a small ampoule like this. And he told me, but don't use it intraorally or clinically, because it's not approved yet. And the main component, I'm just going to say it, the main component of this was nitric acid.
Oh.
And of course, you cannot
Very good.
use nitric acid, yes, intraorally. Of course, we cannot do
In
that.
body.
But yeah, but I tried it already in vitro in some of the teeth. And I was very careful at that time when I'm using them. And yes, it can dissolute a little. It can soften a little the MTA or the bioceramic putty. But I'm not sure about using nitric acid in the oral cavity. And of course, I'm not going to do this. But I'm telling you that it's not something new to have some materials that can remove. There are lots of materials that can remove, and there are lots of chemicals that can remove. The point is it clinically applicable or not?
Yes.
It can be already available for human use or not? This is the question. Because at
Is
that
it safe
time,
or not? Yeah.
yes, exactly.
That's very amazing. Thank you. It's a very new point for all of us that we have a solution which was invented about 5 years ago to dissolve the bioceramic, but it is not safe in the clinical situation.
But till now they have
said
done
it.
nothing. But till now they have done nothing. I think we should notice that we can work on this topic and find some material that are good solvents, so they are not toxic, but they're good for the body, and they solve it, so retreatment can be easier.
You know, but the point is, whenever this is a very good point, but not only not being a non-toxic material, but also not to affect the tooth structure, because at the end, you know, like you have the hydroxyapatite at the end, which is a byproduct coming from the bioceramic sealers due to the hydration reaction. So hydroxyapatite is mainly already a tooth component structure. So we are worried that if something might be affecting the bioceramic sealers or the MTA or the bioceramic putty, it might at the end affect the tooth structure itself. So it's there is more of research and more of development needs to be done at that point. So I totally agree with you, Dr. Paris. Yeah.
Thank you. Thanks. I will send you both the material, because I think it is FDA approved, and we can talk in private about that
Very
solution.
nice.
Yeah. Yeah. And we can check if it is real or we can use it in the future or not. I will send you the photo of that material and the information in the private. Maybe
this is a very. By the way, I would like to thank you so much for that, because this is new to me. And being FDA approved already, it means that it has been released already in the market.
Yeah, it has released.
Yeah,
it's going to be released, and FDA,
going to be.
Yeah, it's going to be, but it is FDA approved.
Okay.
I think.
So now you know things that I don't know. Oh, okay.
We will talk in private. No problem.
For sure.
Okay, for sure. Thank you. Any final comments, my friends, if you have any final comment, if you have anything to ask or talk about, you are completely free, or we can go for the finalization of this session. Parisa and
I'm good.
Mustafa, if it is...
I'm really honored to be with you today, guys. Really, and actually, I think the discussion today was very fruitful. Not only for the audience, maybe fruitful for us even, like sharing ideas, sharing thoughts, and sharing about the different techniques and how audience. So I'm really honored to be with you today, Dr. Parisa, Dr. Ali. Actually, you are amazing guys. I have met you already, and it was quite a pleasure to know you last month. And actually, we have been talking for the past few months, and it was quite a pleasure to know you guys. And of course, Dr. Ihsan, I would like to send my greetings to Dr. Ihsan. He is not here, but I believe this guy is amazing and he's doing a very good job. And the Endo Leaders show is very nice and it's very fruitful for all the audience all over the world. And I believe you are doing very good job. And I was very lucky to be part of this team. Thank you so much.
Thank you. Thanks for
Mustafa.
accepting our invitation. Thank you.
Yes, we had a
Okay,
pleasure. It was really a pleasure.
My pleasure.
Having
our,
you.
Our honor.
Thank you.
Okay, Dr. Parisa, any final words for this session?
I think that Dr. Mustafa told us a lot of new concepts about bioceramic sealer. It was an honor to have Mustafa with us, and we shared a lot of knowledge and update details. And I hope in future a lot of new era in bioceramics for a worldwide use of benefits of bioceramic sealers. Thanks.
Thanks a lot. I should say my words and appreciation to Mustafa and Parisa for accepting our invitation for this amazing and insightful discussion. We have learned a lot from each other, and I know and I'm sure that for all the participants and audiences, this session was very, as Mustafa said, very fruitful and very impressive. Thanks for accepting and for joining us. And for the final words, I want to thank Ehsan for arranging such programs and for gathering us, all of us together at the Endo Leaders Show. He's behind the scene, but he always supports us and helps us to hold such sessions. Thank you. Thanks for everything. I want to end this session. I hope to meet you, my friends, very soon, eye to eye, face to face. Yeah, inshallah, in the near future programs.
For sure.
Ramadan Mubarak.
Thank you. Thank you so much.
Bye.
Bye.
Thank you.
Bye.
Bye.